Okay, so today we're going to be going over quite a few topics for the GI section of the NCCPA blueprint for the PANCE. It's disorders of the small and large bowel, diverticulosis, diverticulitis, toxic megacolon, irritable bowel syndrome, acute and chronic mesenteric ischemia, celiac disease, and then wrapping up with appendicitis. I'm going to stick to the high yield stuff and get you through this so you know the things you need to know for your PANCE and your other exams. So let's go ahead and get started with diverticulosis. So the difference between diverticulitis and diverticulosis is just sac-like protrusions or herniations of the mucosal wall of the colon, but no inflammation, no pain normally in these patients. So this is just the start of it. This is what this actually looks like. You can see the diverticula here in the bowel. So these are just little protrusions seen in the bowel, and these can eventually become inflamed, leading to diverticulitis. But in this stage, it's just these pouches here. So that's all you'll start with diverticulosis. Now, as far as risk factors, diet is really important. This is low fiber, high fat, red meat can all contribute to diverticulosis, and it's mainly because these all lead to constipation. And constipation, when you're bearing down, increases the pressure in the bowel, which can lead to these herniations of the colon. There are some other risk factors: obesity, physical inactivity, and interestingly enough, there's actually a direct relationship between the waist circumference and the incidence of diverticular disease. The larger the waist, the higher risk they found of developing diverticular disease, which is pretty interesting. And then, of course, smoking, like almost every disease, is a risk factor for diverticulosis as well. Now, as far as clinical manifestations, most patients are actually going to be asymptomatic, but there's one thing that you absolutely have to know for your boards, for real life. This is really important, and you'll definitely see this come up. So diverticulosis is the most common cause of acute lower GI bleeds in adults. That is very important for you to know. You will be asked that at some point, whether it's on the PANCE, your exams in clinical medicine, but you do need to know that. Do not forget that. Now, as far as the diagnosis for diverticulosis, you're going to be using a colonoscopy. That's going to be your test of choice. And interesting that a colonoscopy in diverticulitis is actually contraindicated because of the risk of perforation. But in diverticulosis, you want to do a colonoscopy. That's going to be your test of choice. If there is active bleeding in these patients and you don't visualize it on a colonoscopy, you want to do either radionuclide imaging and arteriography if a patient is bleeding and you need to find the source. So those are some other options. But really what you need to know for diverticulosis in general is going to be a colonoscopy. Now, treatment, you're going to start with dietary and lifestyle modifications in an asymptomatic patient, meaning they're not bleeding, they're not having any other problems. So make sure that they're increasing their fiber, decreasing their weight if they are overweight. And then you do not need to avoid seeds, nuts, etc. This is actually a common misconception. A lot of people think that if you eat seeds, nuts, popcorn, those types of things can get caught in the diverticula, leading to diverticulitis. But it's actually found, many studies revealed this was not the case, and they actually couldn't find any correlation between the two. So that's a misconception. You can look that up on Uptodate. That is not anything that's followed or believed anymore, but it was a common misconception. A lot of people still do believe it, so just remember that as well. Now, if a patient's actively bleeding, of course, you need to go ahead and make sure they have IV fluids, blood transfusion, balloon tamponade, etc. to treat the bleed. It's most likely not going to be the way you're going to see diverticulosis in an exam question, though, but just to know that if the patient is actively bleeding, that's the treatment that you would go with. Now, what are the two things I really think you need to know if you're going to forget everything else? Do not forget that the most common cause of acute lower GI bleeds in adults is diverticulosis. You have to know that. And then, of course, know that colonoscopy is going to be your test of choice. Now, let's move on to diverticulitis. I feel like this is a little bit more high yield for the boards, as you might be asked more questions on this. So diverticulitis is when those diverticula become inflamed, infection of those diverticula, and it's generally due to microperforations of the diverticulum. So sigmoid colon is going to be the most common area to be affected, and that's because the sigmoid colon actually has tapering off and it narrows in this area. So you have increased pressure, which causes this increase in the diverticula, and it can lead to these perforations. So sigmoid, most common area, and that leads us to your clinical manifestations, which would be left lower quadrant pain. That's because that's where the sigmoid is. Now, do not forget that diverticulitis is going to be the most common cause of left lower quadrant pain. And if you think of your left lower quadrant of the abdomen, there's really not anything else there. You don't have any organs besides the bowel. There's, your spleen's higher up, your liver's on the other side in the right upper quadrant, Appendix is on the right lower quadrant. So really in the left lower quadrant, there's not much else. So especially because I had this on my OSCE, if you have a patient with left lower quadrant pain, the first thing you should be thinking of is diverticulitis. So remember that. That's the sigmoid area, left lower quadrant pain for these patients with diverticulitis. They also may have fever. Remember, this is an infectious process with diverticulitis. And they also may have change in bowel habits. Now, constipation much more frequently than diarrhea. Actually, patients with diverticulitis rarely have diarrhea. It is possible, but more often than not, they do have constipation. So remember that. And now, as far as diagnosis, remember before we said colonoscopy for diverticulosis is not going to be the case with diverticulitis. With diverticulitis, you're going to do a CT of the abdomen and pelvis. That's going to be your test of choice, and colonoscopy is contraindicated. This is just a look at the CT. You're not going to have a CT like this on the exam to have to diagnose, but just so you kind of get an idea of what it would look like on a CT. So you have the thickened bowel wall. You can see the diverticula in the imaging, and a lot of people, this is not going to be that familiar, so don't feel bad if you can't recognize a lot of the signs and things like that you'll see. But generally on a CT, what you're looking for is bowel wall thickening, which you can see here, and then sometimes you'll have mesenteric fat streaking. That's kind of common with diverticulitis, and the exam is normally ordered with IV contrast. So CT is going to be your imaging of choice. If you do labs, you're going to see leukocytosis, again because of the infection. So on your CBC, look for those increased white blood cells. Moving on to treatment. Now, treatment for diverticulitis, if the patient's uncomplicated, they don't have an abscess, there's no perforation, you're going to initially start with a clear liquid diet. You want to give them bowel rest. So you don't want to have them eating foods and processing all this food through the bowel. So clear liquid diet. And then you're going to give them oral antibiotics. Now, first line is typically going to be Augmentin. It's not 100% of the time, but generally you should know that Augmentin is going to be your first line in most cases. And then your second line generally is going to be cipromethronidazole. Now, what you're covering with these antibiotics is you're mainly covering for gram-negative rods, mainly E. coli, and then anaerobe, so mainly Bacteroides fragilis. So those are the two organisms that you're covering, which is covered by these antibiotics. So remember Augmentin and cipromethronidazole. Either one of those, if it's on the exam question or if you have an OSCE, either one of those would be fine to choose. But generally, Augmentin is going to be your first line. Now, if the patient is complicated, they have an abscess formed, they have a perforation. They have a perforation, obviously, you're going to take them over to the OR for surgery. And then if they have an abscess, it's normally going to be drained via CT or ultrasound guidance. So that's going to be the ways that you treat patients with diverticulitis. Really what you need to know is bowel rest, so clear liquid diet, and then your antibiotics, Augmentin, cipromethronidazole. Now, how do you remember all of this stuff? There's a decent amount of stuff you need to know for diverticulitis, and it's one of those high-yield things that you really need to remember all of those important things. So this is what I came up with. Eating too many clams can cause diverticulitis. Eating too many clams can cause diverticulitis. So remember the word clams, and then each letter stands for something different in diverticulitis. So clams, the C stands for both CT, which is your first line imaging, and it stands for cipro, which is the combination of cipro and metronidazole, which is normally your second line PO antibiotic. The L stands for left lower quadrant pain, most common presenting symptom. The A stands for Augmentin, which is normally your first line antibiotic. The M stands for metronidazole, which is the second line PO antibiotic combined with cipro. And then S stands for sigmoid, which is your most common area of bowel to be affected due to the increased intraluminal pressure. So that is diverticulitis. If you remember, eating too many clams can cause diverticulitis. You'll most likely get the exam question right. These are the main things that they're going to ask you, and these are the most important things. So just remember that. Eating too many clams can give you diverticulitis. Now let's move on to toxic megacolon. A little bit less to know here, but still an important topic for the PANCE. So this is a potentially lethal complication of inflammatory bowel disease. Infection as well as some other causes, and it consists of both colonic dilation over 6 centimeters, remember that, and systemic toxicity. So there's a number of different causes, most of the time from inflammatory bowel disease, that's going to lead to a dilated colon and systemic toxicity. So the way I remember that 6 centimeters, because you do need to remember that, you're probably going to see that in the vignette, is that instead of saying toxic megacolon, toxic sounds like toxics megacolon. So I just always remember toxics megacolon. and then that reminds me that it's colonic dilation over 6 centimeters. So just an easy way to remember that over 6 centimeters for the imaging findings. Now, etiologies, again, the most common cause is going to be inflammatory bowel disease. So think ulcerative colitis, Crohn's disease, those are going to be your most common causes, but it may also be caused from infectious things like C. diff, volvulus, diverticulitis. So all of these can be causes, but remember, you should just be remembering the most common things because the boards are normally going to ask you the most common things. So think inflammatory bowel disease, think a person with Crohn's, ulcerative colitis, presenting with toxic megacolon. Now, history and exam, you're going to have severe bloody diarrhea. That's going to be one of the more common findings with a patient with toxic megacolon. In addition, they're going to have abdominal pain, distension, and then they're going to have signs of toxicity, which is really important. So they're either going to have fever, they're going to be tachycardic, hypotensive. Remember that they're going to be toxic. These patients are very sick. So severe bloody diarrhea, abdominal pain, and then remember your signs of toxicity, fever, tachycardia, hypotension. So don't forget those. Those are very important. Now, diagnosis. This diagnosis is going to be based off of a criteria. In general, I recommend that you don't memorize criteria. There's a lot in a criteria, and normally they're not going to ask you specifically to break down each criteria in a question. For toxic megacolon, when you look at the vignette, what you should be looking for is this patient sick as shit? Do they have colonic dilation over 6 centimeters? If you find those two things, it's toxic megacolon. So that's really all you need to know. But with that being said, I will go over the actual criteria just so you have an idea. So the criteria is you need radiographic evidence of colonic dilation. Normally it's going to be on x-ray. You don't need to go as far as CT in most cases. And if you take a look and that's going to be obviously over 6 centimeters. If you take a look at the x-ray here, you can just see this massive large bowel. It's extremely large. And if you've ever seen a picture of an abdomen, sometimes you'll see gas in the bowel, but it does not look like this. So this bowel is extremely large and it's over 6 centimeters. So you have that. And now you need some other signs of this systemic toxicity. So you need 3 of the following. You need either a fever over 38 degrees Celsius, over 100.4. You need a heart rate over 120, so tachycardic. You need leukocytosis, white count over 10,500, and anemia. So you need 3 of those, and then you need 1 of the following. This is why I'm saying do not memorize this. It's ridiculous. You have way too much to remember otherwise. And then 1 of the following, either dehydration, altered mental status, electrolyte disturbances, or hypotension. So radiographic evidence of colonic dilation on x-ray or CT over 6 centimeters, 3 of those following: fever, tachycardic, leukocytosis, anemia, and then 1 of the following: dehydration, AMS, electrolyte disturbances, and hypotension. So that's the criteria. Again, like I said, on a vignette, just look for a patient very sick with colonic dilation on imaging, and then you have a toxic megacolon diagnosis, and then just answer whatever else they're asking you, whether it's treatment, etc. So that's what you should know for that. Now, treatment for these patients, a lot of it is just going to be supportive. So initially, you're going to need to admit them. Most of the time, it's going to be ICU admission because they are pretty sick. But otherwise, a lot of it's going to be supportive. So NPO, you need to have them on bowel rest, IV fluids, broad spectrum antibiotics. And then you need to treat the underlying cause. Remember, I said this can be either, it can be ulcerative colitis, it can be Crohn's, it can be infectious, it can be a volvulus, whatever it is, treat the underlying cause to help these patients get better. And then the rest of it is just going to be supportive. So NPO, IV fluids, broad spectrum antibiotics, and then just admission to monitor these patients. So what are the things you really need to know for toxic megacolon? I think there's 3 things that you cannot forget. You need to remember colonic dilation over 6 centimeters. Remember, toxic megacolon. You need to know that bloody diarrhea is one of the more common manifestations. And then you need to know that this is most commonly a complication of irritable bowel disease. So those are the 3 things that you really need to know for this. Now let's move on to irritable bowel syndrome. Now, irritable bowel syndrome is a functional disorder of the GI tract where patients will have chronic abdominal pain and altered bowel habits like diarrhea, constipation, alternating back and forth with no identifiable organic cause. Now, if you're not familiar with the term functional disorder, what functional disorder means is that they have a disorder that can't be identified on either imaging or lab studies. So there's nothing specific to point to the cause of the symptoms these patients are having. So that's what's known as a functional disorder. There's no identifiable organic cause. That's IBS. Now, It's most common in women and normally younger patients. So in a vignette, you should be looking for a young woman in their 20s or 30s. That should point you to IBS if you see some of the other symptoms we're going to go over. As far as clinical manifestations, there's a few things that you need to know that will kind of point you in the direction of IBS. One of them is going to be abdominal pain with alternating bouts of both diarrhea and constipation. So kind of going back and forth. And then the key, what I've always seen in vignettes and the way I've always seen it described, is that this patient has abdominal pain, but it's relieved with defecation. That's very important. That's the way I've always seen it. And that's what you need to know to kind of distinguish it from other causes of GI problems. So remember, abdominal pain relieved with defecation. Don't forget that. Now, as far as the diagnosis, again, like I stated earlier, there's not going to be anything that you're going to find on labs or imaging. So don't be looking for leukocytosis. Don't be looking for some CT imaging that's going to point you in this direction. But with that being said, you do need to do those labs and imaging tests first to rule out other causes. You need to know that this isn't diverticulitis, that this isn't some other bowel disease like ulcerative colitis or Crohn's. So you need to rule out those things otherwise, but it's not going to help you to make the diagnosis of IBS, except for the fact that it's a diagnosis of exclusion, but you do have a criteria that you need to know. So there's something called Rome 4 criteria, and this is how you diagnose irritable bowel syndrome. So what this states is that with IBS, it's going to be recurrent abdominal pain occurring for a minimum of 1 day per week for the last 3 months, combined with 2 of the following. The pain is related to defecation, so in some way. So in this case, it's normally better with defecation. Change in stool frequency. So 1 week they're having a bowel movement maybe once a week. The other week they're having diarrhea multiple times a day. So their stool frequency is changing. And then third, there's going to be a change in the stool form. So again, that relates to diarrhea and constipation. And a lot of times in these patients, with the constipation, they'll describe the bowel as like pellet shaped. So it's a change in the stool form. So you need 2 of those in addition to abdominal pain once a week for the past 3 months. So that's the criteria. I know I say not normally to memorize criteria, but this one's pretty easy to memorize. So if you wanted to remember this, it's not very hard. And that's Rome 4 criteria. That's how you diagnose these patients. Now, as far as treatment, you're going to first have them make some lifestyle changes. Dietary changes are really important. They're going to decrease fat. They're going to decrease their processed foods, decrease caffeine, lactose, and fructose is another really big one that can cause some of these GI problems in these patients. So you want to make sure they decrease these things. And then increased exercise also seems to help in IBS. And then you're just going to treat, then quit smoking, of course. I got a couple more here that I forgot about. And then you're going to treat either the diarrhea or the constipation symptoms. So diarrhea typically is treated with loperamide, cholestyramine is some options for the diarrhea. If it's constipation, lactulose, psyllium, polyethylene glycol. Nothing that's specific to IBS. These are just general meds you use for diarrhea and constipation. So that's the treatment for IBS. Nothing really specific here. Probably not going to be a question because it's not very direct to just IBS. It's really just getting their diet better, exercising more, and then treating the diarrhea and constipation. So what are the things that I think you need to know for IBS? You need to know that the abdominal pain is often relieved with defecation. Remember, that's a very important one. You need to know that this is most common in young women. Remember, your demographics are important for picking out these diseases on vignettes. So you need to know that. And then you need to know that there's no organic cause. Labs and imaging will be negative. There's nothing here you're going to identify on those tests. Okay, so that's IBS. Let's move on to chronic mesenteric ischemia. Not a whole lot to know with this one, so let's briefly go over the things that you do need to know. This is also known as intestinal angina, and we'll go over why that is in just a minute, but chronic mesenteric ischemia is caused by a reduction, so ischemia, in the intestinal blood flow, and it's usually due to atherosclerotic narrowing of the mesenteric arteries. Now, most patients are going to have some history of atherosclerotic disease, whether it was an MI, CVA. They're going to have some history of atherosclerotic disease, and now this is presenting in the mesenteric arteries. As far as clinical manifestations, the key here is going to be this dull, crampy abdominal pain that's worse after meals. These patients are going to come in, say, I had a big meal, and all of a sudden, I had this really bad abdominal pain. Normally, it will resolve in a few hours once the food's digested, but they're going to have this pain that's associated with meals. And a lot of times, because of the fact that they have this abdominal pain with meals, they're going to have this fear of eating, and a lot of these patients will start to lose weight. So you're going to see weight loss in a lot of them. They're going to be fearful of eating. So those are the clinical manifestations that you need to know. Diagnosis is going to be made in both chronic and acute with a CT angiography. That's going to be your test of choice. And that'll give you a good look at the mesenteric arteries and see if there's any areas of ischemia. As far as treatment, really the way you're going to treat these patients is with revascularization. So you need to open up these arteries, whether it's with stenting, bypass. That's really your definitive way to treat these patients with chronic mesenteric ischemia. Just like any coronary problem, if you have an ischemic artery, you need to open it up. That's how you treat it. So again, stenting bypass is going to be your definitive way to treat these patients. Now, what do you need to know? There's really not a lot here, but you need to know that most patients are going to have a history of atherosclerotic disease, and they very well may mention that in the vignette, that this patient has been being treated for coronary artery disease and then had this pain after eating a meal. You need to know that the pain is most commonly going to present after meals. I would say that's the most important thing you need to know. Remember that, because that will be the way it's asked. And then you need to know that angiography is going to be your test of choice for diagnosis. So a CT angiography. You can do MR angiography as well, but remember, you're normally going to do CT because it's cheaper, it's faster. You don't have to worry about the patient being claustrophobic. So normally MRI is not going to be your first line imaging. So CTA will be your test of choice for chronic mesenteric ischemia. So let's move on to the opposite end. That's going to be acute mesenteric ischemia. So these patients are going to have a sudden onset of small bowel hypoperfusion, which leads to this severe abdominal pain. So remember, with chronic, it was more of a dull, crampy pain after eating. These patients are going to all of a sudden go 0 to 100 and have this extremely bad abdominal pain. Now, etiologies, there's one that you absolutely have to know, and that's going to be emboli from AFib. Emboli from atrial fibrillation is the most common cause of acute mesenteric ischemia. And remember, it goes along with that acute onset. All of a sudden, these patients are doing okay. They throw this clot, it gets lodged in the mesenteric arteries, and all of a sudden they have this extremely bad pain. And the area where this is most likely going to get lodged in is the superior mesenteric artery. If that is asked, you should know that. So superior mesenteric artery is the most common place for it to get lodged, and it's just due to the diameter, and then it has a narrow takeoff angle. So that's important to know as well. So emboli from AFib, that's the most important. There's a few other causes. Sometimes you'll see it in patients with cocaine use due to the vasospasms. Patients on vasopressors can have this as well. And then patients who are volume depleted and have hypovolemia can also have acute mesenteric ischemia. For the boards, though, just remember emboli from AFib. Now, clinical manifestations. These patients are going to have this extreme pain out of proportion to exam. You're going to do a physical exam on them. You're going to be palpating on the abdomen. You're going to be doing all your different tests and palpating the right lower quadrant and all these things and doing your percussion and blah, blah, blah. And it's going to be a negative exam, but they're going to be writhing in the table in pain. So pain out of proportion to exam. Normal exam, but they're still in this extreme pain. It doesn't make sense. They also may have nausea, vomiting, diarrhea, not really specific, but you do need to remember that pain out of proportion to exam. And then peritoneal signs in advanced disease. So sometimes patients will present with guarding rebound tenderness if they do develop peritonitis. So that may present as well in advanced disease. Diagnosis, again, is going to be CT angiography. That's going to be your first line. And if for some reason it's inconclusive, a definitive diagnosis can be made with catheter-based arteriography. So that's going to be the same way you do like a catheterization for the heart to visualize if there's any ischemia in the coronary arteries. It's the same way in these patients, but normally CT angiography will be enough to visualize the area and you won't have to get to that stage. But do know that in case this is inconclusive, that's another way to diagnose this and really is the definitive way if you need to. Now, as far as treatment, it's just like in a chronic mesenteric ischemia, surgical revascularization is going to be definitive, same way as before we talked about. And if the patient is hemodynamically stable, sometimes they can have a good collateral blood flow, and these patients can actually be treated with anticoagulants, and you don't always need to do a stent or to do some replacement. Sometimes they can just be on anticoagulants if they have this collateral blood flow, which you can see on imaging to see if these patients don't need that further treatment. But most of the time, it's going to be surgical revascularization. And if the bowel, in some cases, if it's been long enough, if it's been a few hours and the bowel becomes necrotic, it's unsalvageable, you do need to do a surgical resection of the necrotic bowel. Now, the things that you need to know, you absolutely have to know emboli from AFib is the most common cause. Do not forget that. You need to know that patients are going to have this severe pain out of proportion to the exam. And then again, CT angiography is going to be your best way to diagnose, the least invasive. Okay. We're almost finished here. We just have a couple more things to go over. So let's go over celiac disease. So celiac disease is going to be this autoimmune mediated inflammation of the small bowel in these susceptible individuals who are exposed to dietary gluten. And more specifically, it's alpha gliadin, which is a protein that's found in gluten. The patho, due to the inflammation that these patients have in this autoimmune mediated process, it's going to lead to damage of the villi of the small intestine. And if you remember, the purpose of villi in the small intestine is actually to increase the surface area to help the amount of food that's digested in these individuals. So it increases the surface area, leading to better absorption of the foods they're eating. Now, if you have a decrease in the villi or an absence of villi, these patients are going to lead to malabsorption symptoms, and they're going to have what we'll go over in the clinical manifestation. So this malabsorption is going to lead to diarrhea, abdominal pain, steatorrhea, which if you remember is that fatty, oily stools, because they're not able to digest and break down the fat that's in their small bowel because of this damage to the villi in the small intestine. Now, another thing that you really have to know, and I was asked this so many times, even on my clinical rotations, I remember my preceptor asking me this, dermatitis herpetiformis is one of the most common extraintestinal manifestations of celiac disease, and that's what this looks like. Dermatitis herpetiformis is going to be this pruritic papules and vesicles that normally are found on the extensor surfaces of the elbows and knees, and it's very common in celiac disease. You really need to know that. That's another one of those key things that you're probably going to be asked, whether it's on your exams, your PANS, your clinical rotations, but definitely know that. So that's going to be a common extraintestinal manifestation for patients with celiac disease. Now, diagnosis, you can do a trial of gluten-free diet. So you have them make sure that they don't eat any gluten for a period of a few weeks and see if their symptoms improve. But normally that's not how you're going to be asked on the boards. In real life, that's not a bad way to diagnose, but that's not normally how you're going to be asked. So what you're going to be asked is the labs. And then the lab that you need to know is something known as transglutaminase IgA antibody. It's the most commonly used screening test, and a lot of times it is enough to diagnose these patients with celiac disease. So that's one you really need to know. It's a serum antibody test, and it's important that these patients are still eating gluten when you do this test, because if it's been a few months that they decided, well, I think I have a gluten sensitivity, I think I have celiac disease, I stopped eating gluten for a couple months, and then you do this transglutaminase IgA antibody, it may come back negative because they've had the absence of gluten in their diet, and these antibodies will disappear. So you want to make sure that they haven't been already adjusting their diet. But that's going to be your most commonly used test. If you do need a definitive diagnosis, you can do a small bowel biopsy. Obviously, this is more invasive, more expensive, but if you really need to definitively diagnose these patients, or for some reason the IgA antibodies came back negative, this is another way to diagnose, and it is your definitive way to diagnose celiac disease. Treatment is very simple, and really the only accepted treatment for celiac disease is just a gluten-free diet. So no wheat, barley, rye, etc. You're going to have these patients avoid gluten. And then what they need as well is actually some vitamin and mineral supplementation, because these patients, again, because of the disruption of the villi and the malabsorption, a lot of times these patients are going to be deficient in B12, vitamin D, folate, iron. All of these things may need to be supplemented, and you can test these things with labs and see what they are deficient in, and go ahead and replace that with vitamins and minerals to make sure that they're not depleted of some of these important vitamins in the body. So that's another thing you need to know as well. And then the three things that you really need to know is that celiac disease is an autoimmune disease of the small bowel. So autoimmune, remember that. Number two is the most important, dermatitis Dermatitis herpetiformis is a common extraintestinal manifestation, and you're most likely going to be asked that. And then, of course, the initial test of choice, and often the only test that you'll see on your exam question, is going to be transglutaminase IgA antibody. So really remember that. Number 2 is your most important. Don't forget that. And then remember the test too. So that's celiac disease. We're almost finished. This is going to be the last thing that I'll go over, and this is appendicitis. Most of these things you're already going to know, but there are some things that I really want to hit home to make sure that you don't forget that are important. Appendicitis, as you probably know, is an acute inflammation and bacterial overgrowth of the vermiform appendix. Now, it's the most common abdominal surgical emergency in the world, and that's why most people are pretty familiar with this already. As far as etiologies, there's 2 that you need to know that are the most common. Now, lymphoid hyperplasia is going to be the most common in children, and this is an increase in the lymphocytes in the lymph nodes, and it leads to these nodular lesions, a lot of times traps the bacteria in and leading to all this inflammation and infection. And then the other cause, which is, these are kind of the same frequency. Sometimes they say lymphoid hyperplasia is a more common cause, but fecalith is going to be your most common cause, typically in adults. And obviously, this is just a stone of poop that gets lodged in that area, and that causes the infection. So that's going to be your 2 most common causes. Now, clinical manifestations, we all know right lower quadrant pain, but you do need to know that while the pain in appendicitis will progress to right lower quadrant, it can initially, and actually in most cases, be either periumbilical or epigastric. So the first few hours of pain, they may actually have periumbilical pain, and then it later progresses to the right lower quadrant. So remember, that's going to be the progression, and they may in a vignette ask you early on that this patient has periumbilical pain, they have some nausea, vomiting, and don't always think that it has to be right lower quadrant. So remember that too. There are also, I can't remember the name offhand, but there's another type of appendicitis that can actually present on the other side as well. So just be familiar with those things. Generally right lower quadrant, but it starts as periumbilical. Anorexia is another really important one. These patients are not going to have an appetite, and then they also may have nausea, vomiting as well, but really just know your right lower quadrant. Fever and things like that are very common in appendicitis. Physical exam. This is the things that you absolutely have to know. These are the things that you're going to be, definitely will come up in your OSCE, probably will come up in a few questions. So you need to know all 4 of the physical exam findings. The way I remember that is I remember the word PROM. So PROM stands for Psoas sign, Roth-Singh sign, obturator sign, and McBurney's point. So remember the word prom, like you're going to prom and all of a sudden you get appendicitis. And then you'll remember the 4 physical exam signs. Now let's go over each one. The first one is Psoas sign, and that's going to be right lower quadrant pain when raising the right leg against resistance with either hip flexion or extension. You can do this either with the patient lying in the lateral position like this, so you have them flex it against your foot or extend the leg against your hand and then push. And as they push, the psoas muscle, which ends all the way in the abdomen, is actually going to push on the inflamed peritoneum. So it lies parallel with the peritoneum. It's going to push on that area. So it's either going to be flexion or extension of the hip, pushing against resistance with your hand, and they'll have this pain in the right lower quadrant. And again, this can be done in the lateral position or supine, and that's going to be psoas sign, which again, just like in the name, it has the area that is involved in the testing, the psoas muscle. Roth-Singh sign, this one is going to be palpation in the left lower quadrant causes pain in the right lower quadrant. The way I remember this is instead of Roth-Singh, I think of Rossfing. I just kind of switch the V and the S around, and then it helps me to remember the sign from it. So instead of Roth-Singh, you do Rossfing, and the ROS stands for palpation in the left lower quadrant will cause pain across the abdomen in the right lower quadrant. You have that ROS and across. And then it also makes me think of ROS as in Rossfing. Palpation in the left lower quadrant will cause pain to rebound other side. So ROS, rebound other side, ROS across the abdomen in the right lower quadrant. That's how I remember Roth-Singh. I just remember Rossfing. And I remember pain in the left lower quadrant causes pain in the right lower quadrant, suggestive of appendicitis. A couple more. Obturator sign. This is going to be right lower quadrant pain with either internal or external rotation of the right hip with a knee flex. So what you do, you have the patient bend their knee up, you take that foot and you do either internal rotation or external rotation, rotate that foot in or out. And when you do that, it's going to cause pain in the right lower quadrant. Again, the obturator on the hip there is indicating the area that's moving around, causing pain in the right lower quadrant. And one last one, the M in PROM is going to be McBurney's point tenderness. This is a pain a third of the distance from the anterior superior iliac spine to the umbilicus. So you can see right here, you have the ASIS, you have the umbilicus. The pain that they're going to have is going to be in that right lower quadrant, which is a third of the way in between those two structures. So that is your physical exam findings. Remember those. Remember PROM. Remember the way I have you remember Rossving instead of Rovsing. And then the other ones make sense because it's psoas sign and it's the psoas muscle obturator in the hip area. And then McBurney's point, not really any way to remember that, but just remember that it's a 0.3 of the distance from the ASIS to the umbilicus. And then finally, diagnosis normally is going to be with a CT unless they're pregnant or a child, and in those cases you can do an ultrasound or an MRI, and then treatment is going to be an appendectomy. Something that's important that I'll note, not really going to be something that's tested on, but in patients that are non-surgical candidates for any reason, or patients that just outright refuse an appendectomy, antibiotic treatment can actually be curative in about 70% of patients with appendicitis. So antibiotics actually have a really good place with treatment, but the problem is about 40% of patients treated with antibiotics will have a recurrence with appendicitis and eventually have to have an appendectomy. But it is an option in some cases. I just wanted to bring that up. So what are the things that you need to know? You need to know that lymphoid hyperplasia and fecalith are going to be your most common cause. You want to know your physical exam tests. Remember PROM, so those 4 physical exam tests. And then remember that the pain early on, and it may be this way in a vignette, is going to be periumbilical region rather than right lower quadrant initially. So that's appendicitis. I just want to add something here on the videos. I think we'll just do a few questions to kind of help you and see, how much you retain from the video and how much you retain from what I went over today. So we'll just do 5 quick questions and test your knowledge and see what you remember. So where is the most common area of the colon to be affected in diverticulitis? So most common area affected in diverticulitis. Remember, that's going to be the sigmoid colon. That's the left lower quadrant. How many centimeters must the colon be dilated to diagnose toxic megacolon? Of course, that's one of the many criteria to diagnose, but you do need to have this. So how many centimeters must it be dilated? I hope you remember this because I gave you a mnemonic. Remember tox 6 colon over 6 centimeters. Question number 3, what is the most common cause of acute mesenteric ischemia? Most common cause. Remember, this is going to be a sudden onset, so it's got to be something that happens quick. So that's going to be an emboli from AFib. They threw a clot from AFib, got lodged in there, and they're going to have acute mesenteric ischemia. Question 4, what is the initial lab test of choice for diagnosis of celiac disease? So what is the initial lab test? That's going to be transglutaminase IgA antibody. That's normally the one that they're going to ask you about. And then last question, what are the most common causes of appendicitis? Most common causes. So that's going to be lymphoid hyperplasia and fecalith. Those are the 2. And then those are the 5 questions. Hopefully you got those right. I hope I helped you. As always, thank you so much for watching the video. If these videos help and you want to thank me, the best way is just to subscribe, like the videos, leave me a comment, let me know that it is helping you. That is definitely a reward for me to hear back from you, you guys watching the video. So thank you so much, and good luck on your PANCE, your PANRE, your EORs, and good luck in PA school.